All right, no worries.
Okay.
I'm an associate professor at Hopkins in medicine and oncology. Took care of tons of COVID-19 patients and then care for a lot of them still in the ICU, COVID, but long COVID patients have trickled into our clinics in various scatterings. We run a long COVID clinic as well, which has its benefits and challenges. And then, we do a lot of community outreach. That's always been kind of my niche, how to promote population health through community engagement. And so here today, Amanda, thank you so much for this invitation and excited to help.
Yeah, thank you so much. Yeah, I still see you pop up on CBS every now and then. They play that a lot.
Good. Hopefully that's okay. Like I know that guy.
You
So,
know, hey, I'm gonna text him and say, hey, you're on my TV again. So let's just jump right into it with our first question. Um, Long hauler cough, is it a thing? I'm having lung issues after several rounds of COVID and one round of influenza A over a 5 year period. Going for surgery and found after a CT scan, I need to see a pulmonologist first, and they need to have pulmonary function test. Is this something that other COVID people have? Do they have lung damage with this?
all right. So let me scale back a little bit
Yeah.
about a cough real
Oh,
quick.
yeah.
So there's once you get past 8 weeks and you still have a dry cough, that's often dry. We do call that a chronic cough. Chronic coughs can happen for tons of reasons. And I have tons of long COVID patients with a chronic cough, but various reasons for it. The most common reason that we see, honestly, is it in patients who already have some level of an airway disease to begin with, like they had a touch of asthma, they have some level of COPD, and now the COVID infection has just made their airway disease more challenging. And so they develop a chronic cough from that. Then we have other patients who they do get some lung scarring from COVID, from these infections. And because of that, that lung scar in of itself may also create kind of a physiological response of a cough. Airway disease coughs are usually because the lungs are just trying to get air out. Coughing from a lung scar, it's not actually common, but we see that for various reasons, and oftentimes just because that area gets infected. Now, those are common, right? I'll put that out there for a lot of viral survivors, virus survivors, not just exclusive to COVID. Now there's this other thought, and bear with me because it's hypotheses. I can't prove it physiologically. And by the way, if you have a chronic cough, what your doctors are going to do, they're going to get a CT scan, they're going to get lung function testing. Lung function testing are great to tell us if you have an airway disease that's chronic and irreversible. And if that's negative, by the way, one other test that I love to go with is a peak flow meter. So I give you this little device, you breathe in it, or you breathe out of it, right? Like blowing candles and birthday candles, and you record when you're at your best. And then when you get your cough, you redo it again and see if there's some airflow limitations in your airways. Those are the three ways I kind of work up a cough. And then finally, there's this category of, for simplest words, and maybe your audience knows this, an idiopathic chronic cough. Idiopathic just meaning we just don't know. But let me tell you kind of our thinking behind this, right? So here's what's fascinating about the airways. There's not a single pain receptor there. Not a single one. If I drop a needle in your airways, you will not say ouch, you will cough. Because that makes sense. Pain receptors should be somewhere where your body can force your attention to where you can physically take something out. The real estate of airways is not a lot. So why give you pain receptors? Not like you're going to go in and grab it. Cough receptors are important so you can get things out. Why I'm sharing that is with that insight, it gives you some appreciation that cough receptors and pain receptors kind of have a similar purpose and so somewhat of a similar structure. Where am I going with this? As we age, there are people who develop like these chronic pain syndromes. And the thinking behind it is your threshold, some way, shape, or form just got reduced. Ways we're still trying to figure out, right? There's not a real chronic pain syndrome, an idiopathic one in pediatrics, nor is there a really idiopathic chronic cough in kids. Reason why we suspect this is happening in adults is something changes our threshold for a cough. We've already, I think it's well established and known that like there's neurological changes that happen with COVID. This beast of a virus is, can kind of plague us from losses of smells to kind of these cognitive changes and mood changes, and in its most subtle of ways. We think it does the same thing with a threshold for a cough. We've known other viruses that can change the threshold. Coronavirus seems to be a really good one. So if you got a chronic cough more than 8 weeks, your lung doctor or your just primary care should put you through the ringer of a workup. Is this an airway disease? Is this a lung issue, right? If you have like significant postnasal drip or if you have acid reflux, you got to work it up. And I'm saying this because sometimes these coughs could be from other things. They could actually be just, one other category that's the most common cough post infection is just a post-infectious cough. Those though tend to last for about 6 months, which makes me look like a wizard because when patients get referred to me, it's been about 6 months and I'm like, let's give it one more week. And then it goes away. People are like, wow, we're playing the Powerball with this guy. But there are long COVID patients, when all of this has been removed, who have this idiopathic cough where we just suspect coronavirus has just really reduced your threshold. How do you manage it? It's tough, right? Like, how do you manage patients with chronic pain? You can give them some level of pain medications, but it's not something that you can do all the time because you need to make them also very functional human beings. For the chronic cough conversation, I tell this to patients, like, I can do what I can to reduce it. I won't be able to take it away.
Yeah.
And so you just manage in that aspect. But I will tell you, to be very blunt, it's probably about a year of diagnostic testing, rule outs before we can give you that diagnosis with confidence. How do I know it's kind of a long COVID, say, cough, we'll call it that, as opposed to a post-infectious? As I said, post-infectious coughs usually abate at about the 6-month mark.
Okay.
These long COVID idiopathic chronic coughs, same frequency, same intensity, hasn't changed. Here's the other kicker for it, and it's boggled my mind. There's not a pattern to it.
Right.
Like,
yeah.
if I get a chronic cough, there's specific patterns that really clue me in. Like, here's my favorite one, just oversimplifying. Acid reflux coughs usually happen within hours of falling asleep.
Yep.
Asthma coughs or airway coughs usually happen at around like 3 or 4 in the morning because that's when your body, for someone who's going to bed at like 10, it's usually when your body begins to change its body temperature as you go from like non-REM sleep to REM, and that ignites the cough. Like, I love that. I love hearing that. So anyway, and that lacks a true pattern is an important aspect to it, but it does exist. Treatment for it is not great. We can just minimize. We can't really ever remove it, other than just removing your nerve endings, right? That's just the frustrating part. It's just your threshold for these cough receptors to be irritated is just massively low. So I'll stop there. This is something that's been a long time discussing, but it is talk to your doctor so you can attenuate it as much as you can to be able to at least be functional.
Yeah, the first round of COVID for me, the cough it hurt. I've never had a cough hurt like that. And I grew up with asthma. I mean, I still have inhalers for asthma, but I haven't used them much in the last few years, but that cough hurt.
Yes, agreed.
What treatment options are available for someone with interstitial lung disease and moderate emphysema changes induced by COVID?
So in regards to, good questions. So interstitial lung disease, a couple things. So interstitial lung disease, it just implies there is scarring and some abnormalities, scarring and or abnormalities in the lung tissue. We call that the parenchyma. What we have to really distinguish here is it interstitial lung abnormalities or interstitial lung diseases? Why we make a big deal about dichotomizing that is abnormalities are just that. It means they're present, they're there, but they're literally not causing any symptoms to you, right? Think about a scar on your leg, right? It had some trauma, now there's a scar, and you're like, oh, but I'm fine. Skin barrier still intact, I can walk, life is good, right? We're not going to make a big deal of it. Calling it a disease implies there's active symptoms. Abnormalities on lung function tests may exist, but again, if they're abnormal, but you're sitting here telling me, look, I'm still running marathons and I'm not going to make a big deal of it, like, you got to match the findings with how your symptoms are in order to kind of think about, well, what's going on? And then you got to figure out, well, what kind of interstitial lung disease is it causing? We have really discovered post-infectious ILDs that have some way, shape, or form just activated these fibroblasts, these cells that make fibrosis,
Yeah.
and they just don't shut off. It's a very rare group, right?
Yeah.
And so I don't want to paint this as a common. The more common group is those with ILA.
Mhm.
I scan them, there's lung scarring. I take a great history. They're doing functionally well. We get them to rehab so they can continue doing functionally well, right? Because your lungs are a muscle. So the best way to compensate for that lung scar, get your other lungs to be healthier. And then they compensate and they do well. And these patients live with these lung scars and it doesn't really affect them. So that's what I would highly suggest. Does that make sense?
Yeah. Yeah.
There was a part two to that question. Did I miss that?
Uh, let's see. They just wanted to know. Oh, they were talking about ILD and moderate emphysema changes induced by COVID.
What was the last part? I know you said ILD. The last part was
Oh, moderate emphysema changes.
okay.
Yeah.
All right, hold on one second. Quick message.
Oh, you're good. You do more in a day than anyone I've ever known.
I try. Okay. So emphysema is incredibly common finding. I would say not from a virus per se. So if you do find emphysema in scans, it's oftentimes due to something else and not a virus, because especially how this virus works, it's unlikely to cause emphysema. It can cause the scarring, it can cause airway disease. Emphysema tends to come from a constant exposure to really noxious stimuli and chemicals from the air. Like it takes a while to develop. So one-time infection, like infections shouldn't do this, mainly because that's not how they infect. They don't get to the alveoli. There's other systems that kind of protect it. Even if you've developed a pneumonia, the residual consequence is fibrosis.
Yeah.
To get to emphysema, you need such noxious stimuli that it's overburdened the ability to make new alveolar cells. That's why we predominantly see it, for instance, with people who smoke, with people who live in bad air pollution. Now, second part, you do get a lot of patients who got COVID and have moderate emphysema for other reasons. And the other questions always to me is like, does one influence? If it's not causing, does it influence? Is there an association? Yes and no. Most of us can live with emphysema and just never know of it, right? Having that abnormality, it takes a significant amount of emphysema to pivot it to a disease, right? Your lungs are incredibly robust. They are incredibly resourceful. And I have a ton of patients that we scan. If you scanned everyone 50 and older, you're going to find some level of emphysema because we've all breathed in some bad air, right? If you've lived in downtown LA for at least more than a decade, you're going to have some bad air, moderate, you might have some mild emphysema. So the question is if emphysema influences how air leaves the lungs, and if your COVID infection resulted in some airway issues, yeah, the moderate emphysema may cause some exhalation challenges, an obstructive lung disease. So the emphysema and COVID can be influencing towards your symptoms, but not a cause and effect. And again, like getting into the lung tissue, the outcome is very different. Finally, what I would say though is that all of this necessitates a lung function test.
Yeah.
Because when lung function tests, what I'm looking for isn't just to assist with a diagnosis if it's causing airflow limitation. Airflow limitation to the lay audience means air gets trapped. These are patients who are telling me, I feel like my chest is heavy. It is heavy, and I can't shake it off. So that's where my mind is coming from. But again, and there's good inhalers for that. You just got to find the right one that works for you.
Yeah.
So thank you, Amanda. Great questions, by the way.
Oh yeah. Thank the group. They made them. I think I only contributed one or two this time. So. Should a person who has asthma and experience a lot of lung issues with COVID have a CAT scan for to evaluate for scarring? I had a horrible cough for 4 months. We talked about this. And continue to have shortness of breath with exertion, and my oxygen saturations drop around 90 at night.
Yeah, so great question. Here's how I would think of this. If you, what I love is every patient knows themselves better than any doctor. So if you have an underlying asthma and you got infected with COVID, and now you suddenly realize your asthma is harder to control. Yeah, tell this to your doctor. I would 100% rescan you. It doesn't mean you're going to get lung scarring, but I just want to make sure I'm not missing anything else,
Right.
right? So two things that I do for patients like this, like I know you got an underlying asthma or COPD or something else. If your symptoms don't go back to baseline, I rescan and I redo lung function tests just to see what I'm dealing with. And if those are negative, those are fine. I'll also check on the heart. Because the heart is a very, oh, what a
Yes.
fragile little organ. Anyway, that's why I like my lungs. This is not meant to be jets into sharks with heart and lungs,
With
but
your heart.
yeah, heart is just so fragile. Anyway, um, that's what I would pursue. I would just redo some objective testing. And look, it's not like we're dismissive of the symptoms. We want to treat them. We just want to be as strategic as possible.
Yeah.
Because I will say also, there's a good portion of my patients that their lung disease never got worse, but they
Yeah.
got,
Mhm.
kind of like this unique myocarditis that they didn't pick up on. And then they get an echocardiogram. They're like, I have heart failure. I'm like, well, at least now we got a cardiologist to get on board. So
Yeah.
your symptoms from a lung standpoint are worse and you've been worked up objectively and those objective numbers don't look worse, then I would just reassess the heart. And if it's not the heart, then look, at the end of the day, it also might be long COVID. I have plenty of patients with asthma and long COVID, right? And I make it clear like their pulmonary symptoms, and they will tell you too over time, like, yeah, it's not like I'm wheezing. It's just I'm breathless, but it's not like my asthma breathless. It's a little
Yeah.
differentiation there.
I know exactly that feeling. Yeah. It's not an inhaler thing.
Yeah, yeah.
That's
No, and
fine.
this is so important because long COVID dyspnea, long COVID breathlessness, inhalers, sure, everyone's welcome to try it, but it
Yeah.
doesn't tend to resolve it because it's a different pathology that we suspect. I have nothing against trying, like for some, the inhaler may work, but the inhaler's not going to go to a diseased area and fix it. It's just seeing if I can just open up your airways even more. Will that be helpful? But it's hit or miss for a lot of patients. But yeah.
Get a bike pump. Let's see. I've noticed that, yeah, I've noticed that I get a deep but subtle rattle in my lungs, but only when I'm tired. And I notice this more during allergy season, especially if I'm taking Benadryl. What might cause that?
Did he say deep rattling?
Yeah, like a deep rattle in their lungs.
Yeah, so a couple of things, especially during allergy season, if you know you have these seasonal
Oh,
symptoms, it could be secretions that are overly produced. Because that's like your body's fight towards allergens. Like it's just saying, like, I don't like this here. So it
yeah.
doesn't make a lot more secretions and it could be from nose to lungs. So the rattling you may hear just might be the secretions that are coming about. Um, that's oftentimes the case that I've seen. Heaviness, if there's any heaviness with that rattling, that might just imply there's a little bit of airway disease that inhalers can help with. But most of the rattling that I'm, at least has been shared with me, tends to be this like secretions that they're feeling, congestion. And especially if it's supplemented with a cough, even more. So like that's the case. By the way, I have nothing against Benadryl. If it works, it works. It just
Right,
has a few side effects that I'm just
right.
mindful of.
Yeah.
I always try to lean people towards like loratadine, or zitieracine.
Yeah.
So I think that's Allegra and Zyrtec. I try not to use name brands, but apologies. No
Yeah.
one's paying me, I promise you. Amanda has bribed me with coffee, but just
Well, I just want my Kalamata olive, sir.
there you go. I'll put that on my disclosure form though.
Thank
So
you.
yeah, so I'll leave it at that. The rattling is often what you hear is usually due to the secretions.
Okay.
Um, that's it. Back to you.
Oh, thanks. How would you know if you had microclots?
So it's a good question. I
Right?
don't have an actual really good answer
Yeah.
that is a clinically available tool, right? Short of a lung biopsy that I wouldn't put anyone through just to get it done.
Yeah.
Many reasons. Let me tell you why. One is I don't have an actual answer or intervention to offer that because
Yeah.
while we see it, like you may say, well, they're microclots. How about a blood thinner? Blood thinner for microclots is like using like a nuclear bomb to get to a bank robber,
Yeah, we
right?
don't.
I'm going to create a lot more collateral damage. And the
Yeah.
challenge with microclots too is they usually run through a cascade that, it's just a smaller one compared to the larger ones that a blood thinner would tackle. So like what I'm trying to get at is I don't have an intervention to tackle it, right? And there's nothing wrong with, hey, we have a lot of understanding of the biology of it, and
Yeah.
sometimes we don't have an answer. So what we do to pivot from research to clinical is, what are the symptoms associated with it?
Yeah.
We'll look for that. But to know if you have microclots, short of getting biopsied, which again, it's really hard for me to ever tell a patient, we got to do this for a microclot. I tell them, look, you have the diagnosis. This could be one of the reasons it's happening. And I would say, let's leave it at that. Until we have maybe a biomarker or some other compatible diagnostic metrics, right now the microclot conversation is in the world of the research and academics, which is fine, because again, that gives it the right spotlight. Let me give you my best example. I've had several really to the T long COVID patients. They did get lung biopsies for various different reasons because there were some abnormalities there. None of them were ever found to have microclots. But to me, it doesn't dismiss the microclot biological hypothesis. It carries legs. It has a strong plausibility. It just means to me, like the patients we've seen microclots on tend to be from a autopsy. So you got more areas you can biopsy from. So for right now, I would say if you have the right diagnostic symptoms, that's sufficient enough. And until we have a good intervention for it, one that we can recreate is generalizable and fits the populations appropriately, I don't know how to pivot the microclot research perspective into clinical action.
Exactly. Yeah. And it becomes a matter of, is this going to do more harm than good?
Yeah. No, and it's spot on. And that's what we're trying. Look, I would say my big overarching comment to all of this is if you find the right healthcare team that is advocating for you, stick with that. Because I like to say my colleagues can do everything. We really can't. Like, there's going to be a much more research-oriented groups. Good for them. Amazing. They may be like the driest human beings, but it's okay. We love them. But then if you have a clinical group that's much more advocating, good. Stick with them. It's hard to find a group that can pull off both well, which is fine. It's just a criticism of modern medicine.
Yeah.
So that's what I would say. It's just, if you're long COVID diagnosis, if you feel like you want to be more involved in advocacy, do that. If you want to be more involved in the research, do that. But what I really hone in on is find a clinical team that is advocating for you.
Yeah. Find what works for you. And if it's not working for you, keep looking, ask for help.
Yes. Exactly.
There are a lot of us out here, and that's what this group is about. It's about sharing what's working, what's not working. So let's see. It seems like every 2 to 3 months, I believe I have a new ailment. Do I have these things like MCAS, POTS, ME/CFS, or do I drop them and then they come back? What's going on?
Wait, how did that question start?
Let's see. They said every 2 to 3 months, they have a new ailment that pops up, and they're things like MCAS, POTS, ME/CFS. And they don't know if these are things that are going away and coming back, or what's going on.
So here's a big request.
Yes.
Just overall. Okay, I'm gonna sound like an old man. One of my frustrating things about modern medicine is we are very quick to try to give something a name, right? And sometimes, especially with long COVID, this has really come to light where we're like, it doesn't really fit this, but I'm going to call it anyway.
Right. Yeah.
What I've really encouraged all of my patients is, look, I may send you to other specialists just to make sure nothing else is going on.
Yeah.
But what I'm going to do is just capture your story and your narrative. Because what I find is you actually have the same symptoms popping up. You just got different names over time because we don't know what this is, but we're going to try to put this square peg into some round hole and just cram it in there and say we're done. And then patients get confused. Like every few months, it's kind of the same symptoms, but it's called something else now. And it sounds odd to them.
Yeah.
My biggest plea is making sure longitudinally you just document your symptoms. Don't feel like it's got to abide by some modern medical term. It won't, right? This is a new pathological syndrome, right? We call it long COVID. We have a culprit who caused it, but we still are trying to understand all of it, right? So to me, it's more of a syndrome than a disease. And they're the same thing. It just means disease. Yeah. Like, for instance, AIDS, the reason why there's an S there is because we didn't know what caused AIDS. So we called it a syndrome. Syndromes just mean there's an unknownness. So what I plead with patients is it might sound odd, what you reported, and I don't know your story, like, but you're getting kind of the same terminology for likely the same symptom, different terminology for the same symptoms. What I would say is focus on those symptoms, because what I'm hearing is every few months I get these symptoms back. And that's been incredibly common with long COVID, massively common. You have patients with a plateau of symptoms. You have patients that have this remitting, relapsing symptoms. And then you also have some patients whose symptoms have gone away. And then 2 years later, they're knocking on my door, like, they're back. I'm like, oh, this is good to learn. I need to learn this.
Right.
So all of this is so important for us to take in. What I plead with you is don't worry about your symptoms conforming to some other medical terminology, because it's going to create confusion. You're like, well, you called it this month and this month. I would just call a lot of this, I just dump for the time being into a category of dysautonomia from long COVID.
Yeah.
And I plead that yeah, sure. I mean, from a research perspective, it creates chaos because it's not standardized. Understood. We got to live up to that and we'll get there.
Yeah.
But otherwise, we just cause a lot of confusion for patients. Anyway, I take this question and I'm extrapolating towards very personal situations with patients, and exactly
Perfect.
and I'm like, this is really weird. Like, this is not the natural course of these diseases. And then they just explain this to me, and I'm like, you're having the same symptoms. I mean,
Yeah.
you get some intensity changes. So, but all right, one last thing. This is not to be critical to my colleague, but one last thing though is sometimes I can understand them doing this for the sheer purpose of billing to the insurance gods, because it's the only code that they'll accept.
Yep.
Make sure those doctors tell you that.
Yep.
Because if you leave and you're looking at your medical chart, you're like, wait a second, have POTS? You call the doctor, POTS? You didn't tell me that. Like, oh no, but I don't know what you have. I just can't bill for, I don't know, shrug emoji.
There's no code for that.
Yeah. So just be wary. And it's not like they're trying to be mean. They're just trying to figure out, well, how do I categorize this patient? And that's it. Just talk to the doctors. Or if they don't talk to you, then just find other doctors.
I coded for 20 years and I actually have had to go back and tell them, okay, you can't just say, I don't know. Let's figure something out here. I know you don't know, but there's no code for I don't know. And yeah, and with the anthropology background, we talk about structuralism and functionalism, where humans have this need to put labels to things so that we can bring order to the chaos. Sometimes you need to be comfortable with the chaos until we can get it sorted out.
Yeah, but you know, medicine's never, it's not like it's always been that way.
No.
So what if you guys are ever my residents or interns, maybe there'll be some point. I always take them to the pathology library.
Yeah.
From the old one, right? So there's books from the 19th century, and I'm like, just read it for a second. So we'll read passages, and what they're really astonished by is like, they didn't know what disease this is. I'm like, what disease do you think it is? And they're like, I don't know, maybe it's pneumonia, tuberculosis. But what they're astonished by is how well those doctors were able to describe the descriptions of the slides, of the disease, of the outcomes. Beautiful, chef's kiss. We've lost that because we're trying to cram something into some. Did it fit all 5 categories? And then we'll give it this, that.
Yeah, and the insurance goes go with it.
We lose the art of description. We lose the art of succinctly capturing this in an elegant way. That's what we need, in my opinion, for any time Mother Nature throws at us some different syndrome. Like, we need to default back to knowing what skills make us good, and that's listening, and that's descriptions. And right now, I think it's also been one of the challenges with long COVID patients. Every doctor is very quick to try to give us some diagnosis, and they think that's the end all be all. But then you just really, unfortunately, put these patients down some inappropriate clinical trajectory. And then they're wondering why it's not working for them. Well, it's like, it's not the right diagnosis.
Yeah. That's so true. My mom's a HIPAA, by the way. She's the one who makes the slides. So I'd love to learn more. I would love to learn more about how I can have shortness of breath with O2 sats reliably in the 90s, clear lungs, excellent lung volume, but I have all these other things going on.
Yes. All right. So couple things about breathlessness. So I'm going to answer it broadly and then direct it towards your question. So your lungs can be breathless for many reasons, right? So remember what the lungs have to do, right? They have to get air in, they have to get air out, and they have to filter air. Those 3 things in the physiologically normal lung. All these 3 things can cause breathlessness, right? If they're struggling to get air out, you're going to be breathless. right? My asthma patients, my COPD patients are these people, right? And they're checking their pulse oximeter, but it shows my oxygen's fine, right? Pulse
Yeah.
oximeter captures only one part of the
Yeah.
lungs do well. So if anything else is disrupted, it's going to be just fine. Oxygen being the issue, I will tell you, does it cause breathlessness? Sure, it does, but it causes more anxiety and intensity, right? Your lungs, to get oxygen to the blood, have a little over 10 million alveoli. It's really resourceful. It's really hard to lose the ability to oxygenate. Now, your ability to get CO2 out, that's a little easier because all the CO2 has to like cluster into airways and you have less airways. So you can get someone to be breathless from a lack of exhalation much faster than inhalation. Inhalation, the lungs will find a way. See this because breathlessness with low oxygen is not just I am breathless. It is also like fear, panic, because you're like air hunger, like you
Yeah.
are screaming for air. Breathlessness from everything else is like the breathlessness you get when you're like, oh, around a marathon. I am short of breath, but I'm not air hunger. Like I
Yeah.
need air. Like, so that's the dichotomy I try to tell patients, like oxygen issues, like it's a more of a rarity, but CO2 or filter issues. So what I mean by filter is if the lungs breathe something in they just didn't like you're out the wildfires, right? You put the mask down, you wipe your sweat, you breathe in some combusted air, put the mask back on, but now your lungs, they're filtering something they don't like. You get tight, you get wheezy, it's reactive. So that's the other part, what that can cause kind of normal levels of breathlessness. All that said and done, long COVID breathlessness, I think is on par with its dysautonomia.
Yeah.
There's some way, shape, or form, you have been rocked into the brainstem. The brainstem's ability to send signals to the phrenic nerve, to the diaphragm, have been thrown off. Just like the vagus nerve to the heart, and you get all these dysarrhythmias. Same concept. Long COVID breathlessness. I'm not going to curse. I was hoping you'd like beat me. I was going to say it is a beep
I can be.
because I have nothing to fix it. Like we will
Right?
teach them breathing techniques, but it's something that will subside. It's not an oxygen issue. It's not a CO2 issue. It's not a filtration issue. It's for whatever reason, there's misfiring with the signals and the diaphragm kicks in a little bit awkwardly. And now you have this breathlessness. I can say this with much more confidence now than the last time I came because every patient inventory I take, it is the same. It comes on out of nowhere.
Yeah.
It may wake them up. It could happen when they're watching Netflix. It could be happening while they're watching this program hosted by Amanda Finley. Like it occurs and it's frustrating to them. And look, as a lung doctor, I'm like, look, try this or that, but it self-resolves, which is good, but it's frustrating for me that I don't know how to predict it, how to manage it, and it's
Yeah.
debilitating. It is debilitating to patients. So I gave you three reasons most people become breathless. Long COVID breathlessness, the best I can give you is it's a dysautonomia from the neurological standpoint. What has worked is learning some breathing techniques. And here's the part, like I can't promise you it's working because it's actually doing something or it's working just because there's a time bias. And by the time you're kicking this in, it's also self-resolving. But it's one of the reasons, look, not to sound, I don't know how I'm going to sound, but it's one of the reasons we were trying to promote singing for a
Yeah.
while,
Yeah.
right? That operatic singing. Oh, by the way, I got a new
Yeah.
vinyl. I mean, Amanda actually knows this. She knows I collect vinyl opera
Uh-huh.
recordings.
Yes.
And I tracked this one down. So this was Mozart's, one of his first
Oh
operas.
yeah.
Yeah. But I
Yeah.
found it hasn't been played in over like 150 years. I tracked down the performance that brought it back.
Oh
So,
my gosh.
yes. Anyway.
Wow.
Okay. But one of the reasons we were trying to promote singing is because of, especially like operatic singing, is because of the way it forces your lungs to trap air and it
Yeah.
really offsets the phrenic nerve a little bit. So you can kind of override it. It is almost analogous to like when people say, oh, if you have a certain arrhythmia, bear it down to activate your vagus nerve to squash it. That's what we're trying to do here. The equivalence of bearing down is literally how opera singers train.
Well, actually, what we do, we take something like a coffee thermos or something like this, and you basically you're just shoving it, you're shoving it kind of down below your diaphragm, and you want that, then you want to put that pressure back out on that, push that out, and that sort of grounds you and gives you that breath support.
There you go.
That's how we do it. So learn something new every day, don't we?
I love it.
Okay.
Love it.
Let's see. Okay, and this sort of gets a little bit more into this. How do we know, or blah blah blah? What is the mechanism for how oxygen in our blood is not necessarily getting into the cells to do its job? And that, I don't know.
You mean from COVID or from something else?
They didn't really specify from COVID or something else, just in general.
So how oxygen just doesn't get to the blood?
Yeah.
Per se?
Yeah, how oxygen doesn't go from the red blood cell into the cells, other cells.
Yeah, so oh man, I will. Well, so there's various reasons that may happen. The two big ones that I'll highlight here, and not to say these are very COVID centric, but one way could just be the integrity of the red blood cell. So a big example is like a sickle cell patient. They got oxygen to it, but like then the integrity of the red blood cell breaks off and the oxygen doesn't get there. I have thalassemia, so sometimes that's an issue on our end, which is these micro red blood cells. So sometimes it could just be the integrity of the red blood cell. And especially if you have a pathology that impacts the red blood cells in general. The other way this can happen, so the red blood cell, to give oxygen to the rest of the body, relies a lot on kind of a passive diffusion. There's a little bit of action, but it really relies on cell contact with the wall, the endothelium, and then just transfer of oxygen in there, the capillaries especially, specifically. Now, so the answer is, so what if those capillaries are dilated? It doesn't really touch the wall. It doesn't then transfer any oxygen. I see a lot of that. Again, not a COVID-centric situation, but I run a rare disease for vascular malformations. So we see that lack. Like I'm sitting here, I'm giving all the oxygen in the world to these patients. Nothing's happening to their numbers. It's called a shunt physiology. And so we see that in patients where there's enough of the dilation somewhere in the capillaries that the red blood cells are just never prompted to just give off their oxygen that's bound to them. So those are the big two reasons, I would say, where you can see a miscommunication between red blood cells and their handoff of oxygen.
Okay, cool. Why hasn't pulmonary rehab worked for me, and why does it work for others?
Yeah, I'll tell you why.
But yeah.
That's what we're battling, right? So if I have a long COVID patient that I think you have dysautonomia with your breathing, pulmonary rehab is not going to help.
Yeah.
It may, if it teaches you some reasonable breathing exercises, sure, but it won't. Outside of that, like it's like saying for a POTS patient, go to cardiac rehab. Yeah.
Wind up on the floor.
The others that it helps, it depends again what COVID did to them. If I got your lung to be scarred, pulmonary rehab will help, right? The intention there is go and strengthen the other parts of your lungs. And you can only do that if you are working out. So if your doctor's sending you to pulmonary rehab, ask him or her, what am I trying to improve in? And if they're just, oh, your breathlessness, hand waving, it's not good enough. Like for instance, with my COPD patients, if I send them to pulmonary rehab, my intention is for them to learn breathing exercises, to strengthen the healthy parts of their lungs so they can compensate for the worst part of the lungs. That compensation is important because your lungs are very smart. If they realize you're using them effectively and they can't get the proper gas exchange happening in diseased parts of the lungs, it moves it elsewhere. So I will send many long COVID patients, if they have lung scarring, to pulmonary rehab, and that's the benefit they get out of it. And it's cool. You get to see the healthy lungs over time grow, the scarred lung kind of reduce. But what I would say is, whenever you get sent to pulmonary rehab, ask your doctor, what is your end goal for me with this? Because if they're extrapolating the wrong outcomes onto you, then that might not be the right use of your time. So again, why it works for some and not for others with long COVID, one has to do with the fact that this syndrome is it is so variable, right? The spectrum, the phenotypes, A lot of variability. So yes, I would not expect it to work on a long COVID patient with normal lungs, normal lung function test, and it's more of a dysautonomia breathlessness. Would not expect it to work for them.
Yeah, which makes sense. That makes a lot of sense. This one is it's a bit lengthy. Let me see if I can sort of break this down a little bit. Someone who started out in 2020, they were having problems just walking across the room, and they would get really short of breath. Drinking water made them short of breath. Albuterol and other meds helped, but their O2 sats remained okay. But they would get this loud rattling sound, and that would last about 45 minutes. Chest X-ray was normal. CAT scan 2 years later showed lung scarring, and they needed more asthma medication over the time. They just don't know what's going on with them. They don't know where to start.
Okay, you got to walk me through that one more time.
I know it's a lot. It's a lot.
Yeah, which is good. It's good. It's
I'm,
good. You guys are great. You guys are great. Like, and Amina's given. I think you shared questions before with me. I just haven't looked at them. Part of me likes come in here and like let's do it in real time.
Yeah.
Walk me through again.
Okay, I'm just going to read what they've got here. That'll be easier. About a month into my May 2020 COVID infection, I got short of breath just from walking across the room or even at rest. Drinking water made me short of breath. Albuterol helped, but my breathing became more rapid and increasingly labored. It made a loud rattling sound, and I could speak only 1 to 2 words at a time. My O2 sats were normal, though I had to huff and puff mightily to keep it there. This lasted 45 minutes. Nothing like this had ever happened to me before COVID. Chest X-ray was normal 2 months later, but a CAT scan 2 years later showed lung scarring. I needed a lot more asthma medication than normal. What was going on with me?
Yeah, so I'm curious. I mean, it sounds like there's two things happening, right? There's
Yeah, it does.
you have lung scarring. Lung scarring is a lung tissue issue. Asthma is an airway issue. So I think what you'd have to try to decipher is who's acting up. Asthma doesn't cause those kind of symptoms. I mean, it causes unique symptoms, but not necessarily those. But the fact that your albuterol work, maybe it'll just you open up some airways to compensate. The lung tissue scarring is fascinating to me because I'm wondering what that is, right? Because if it didn't appear, lung scarring from COVID happens pretty fast. So if yours happened years later, my thinking is because one of the points you made was like when you were drinking, right? It was like they were drinking and then they became breathless. Did I read that correctly?
Uh-huh.
So one of the things that can happen, and again, I'm not trying to put this as a COVID thing, so this is just general medicine, is reflux. So not like I have massive heartburn, but sometimes at some point in time, like the chemical fumes you just inhale that your stomach made, I've seen that to patients. They'll drink and then they breathe in these chemical fumes briefly opened by the esophageal gastric sphincter. And, as it's welcoming liquids in, chemical fumes come out, you inhaled it, and it just causes horrible breathlessness. I'm saying this because I'm curious what those scars are. If they're in areas that are much more vulnerable to acid inhaled toxins from the gastric contents, it forms a very specific pattern.
Yeah.
So that kind of story, what I would ask is go back to your doctor.
Mm-hmm.
Doc, scars on my lungs. It's
Where?
pattern. What are you thinking? What could this be? Could this be like an acid reflux? An acid reflux, I'm massively oversimplifying, but it is part of a spectrum where it's not like you're feeling heartburn. You're just feeling kind of the aftermath and the inhalants into the lungs. We've seen this in patients. Yeah, and honestly, we've seen this a little bit more in long COVID patients. I just don't know how to make that connection yet.
Yeah, it's and we've got 3 town halls with some GI specialists who they actually study motility, and we have that reduced motility going on, weakened sphincter. So yeah, we see a lot of this.
Good. Oh, my GI doctors hate it when I send them patients.
Oh, okay.
Not my lungs are bystanders in this causing symptoms. You fix your GI stuff first.
Cage fight out in the back. Let's see. Why are so many people diagnosed with asthma after COVID?
So why are so many diagnosed with it?
Yeah, that's probably more perception, but I don't know.
One of 2 things, and this is the part that, like, again, I'm massively going to oversimplify. One, so let me put it this way. When I get a patient in my clinic, even long COVID patients, I am asking to time travel. Yeah. I need to know about your birth. I need to know about your childhood. I need to know about A, B, and C. Because what I pick up on these subtly is it sounds like sometimes you have these patients who had issues when they were kids, but they're
Mhm.
kids. Kids rebound very nicely. Right now, I have a friend whose son went into a medical ICU, pediatric ICU.
Oh,
Because I just want my kid to run and play baseball. And I was like, oh, he will. They'll be fine. You call me the when he's like 36. He might have some issues then. And so what I'm getting at is one of the reasons could be things that happen as a child that you compensated for as an adult. Well, that compensation gets lost when you got COVID and just resets the lung status. And so you discover you have asthma. In reality, you had all the risk factors to develop it. You just needed one more nail in that coffin. And they use that for Halloween purposes. And coughing sounds like coughing as a lung
yeah.
infection, pun on words. I'm not using that to be morbid. I apologize.
Oh no, we are very morbid in the group. It's okay.
So one of the reasons could just be that aspect. Two, coronavirus is a epithelial invading virus into the airways. Not in the beginning. In the beginning, it was much more lung parenchymal. We had a lot more,
Right.
walking pneumonias with it.
Yeah.
Keep in mind, that's not advantageous to the virus. That's why you saw this mutate more into an airway infiltrating virus. That's more advantageous to it. Why? Because you cough that out, right? If it tickles the airway, then I'm going to cough it. Loves that. Then it gets to spread its joy to all these other people. Causing silent pneumonias doesn't do that. So it's very frustrating. That's why you saw it become a much more contagious bug over time for other reasons. But that's a big driver. If I can get a virus to cause coughing, it loves it. It's a holy grail for transmissible diseases. But being an epithelial cell, an airway infiltrating cell, means it may give you airway level diseases. Asthma is a massive oversimplification of an airway disease. It frustrates me as a lung doctor because it takes no intellectual time. And then you create like these thousands of asthma phenotypes, and then they're all like, well, why isn't this working for me? It's an asthma medicine. I'm like, I know, but your asthma is very different from their asthma and so forth. So asthma we may use as a massive oversimplification. I tend to use more of like a reactive airway disease. It's
Mhm.
splitting hairs, right? Because asthma has symptoms that last a little bit longer than reactive airway disease, but at least the former part allows me to still think uniquely about this patient, where asthma forces you into an algorithm that might not be the right thing for you. So I'm going to take that question and scale back and say, there's a lot more airway diseases happening post-COVID infection for one of these two reasons. Maybe you had the right predisposition and just rocked it. Two, it's a much more airway invading virus, so it's going to cause more airway issues afterwards. So it's likely just a combination of the two. That's it. Mandy, do we have time for one more question?
Yes, we sure do. Let's see. Let me pick one here. Oh, okay. I'm going to sock this one to you because this we've got our next town hall will address this. And it's kind of serious. Am I going to die young because of long COVID? I have a family history of heart disease and would like to know what I can do that's preventative, especially since I can't exercise because I have long COVID.
So if you asked me this question like 2 years ago, I'd say no. Like, we haven't seen anything that long COVID does from a vital sign perspective that is going to threaten your life. It is going to massively disrupt it. It's going to massively inconvenience it. But there hasn't been anything that I would say is going to be resulting in life-threatening. I was also saying that with an asterisk, because I was hoping, what I'll see over time, our patients coming forward and be like, there's a resolution. My symptoms have self-resolved. Or us as a physician, like, we got a cure.
Yep.
It's buying time. Now where I'm at, talk to your doctors. First of all, I'm not trying to say, I'm going to say now kind of yes, but still with an asterisk.
Yeah.
Because we still see these debilities, right? And so here's kind of the mentality that I'm thinking of. When someone says, will I die of HIV? The answer is actually no. It's just what HIV causes.
Yeah.
The opportunities for other infections to come and destroy you, right? HIV will lower your immune cells. Something else is going to come and take that moment in time and be an opportunistic infection, kill you. I'm seeing that happening with long COVID, right? It's creating opportunities for other diseases to surface and say, aha, I got you. You have heart disease. Can't do the lifestyle changes. You have a much more sedentary lifestyle. You died of a heart attack. right? So I'm seeing that. And again, I want to paint a better picture.
Yeah.
I think it has an opportunity now, knowing how sedentary it is causing. Here's another better example too. So like people are like, will I die of my ALS? In reality, you're going to die from what ALS caused you, right? You may aspirate, you may have more infections, you may get a UTI that's bad. Those are the things that it just sets up the opportunity. And now long COVID is, to me, is transition that seeing patients now 5 years fighting this, and they are a shell of themselves. What I plead with everyone is find a medical team that's advocating for you.
Yeah.
Because that's how we can keep these opportunistic things at bay. Find advocacy.
Yeah.
And if you struggle, you got Amanda. If Amanda struggles, she's got me. We will help.
Right.
Find
Exactly.
advocacy.
Exactly. And I won't lie, I've buried 4 people just in the last year from this group. So it's a very legitimate question. And yeah.
Amanda,
But
squeeze a quick one in. It's 3:59. We got
okay.
one more.
How about what can I do to get my doctors to wear a mask at my visit? Why aren't they wearing a mask and why aren't they pushing for it? I hear that a lot.
Oh my God. So I'm a lung doctor. This is very biased. Everyone in my lobby is coughing and sneezing and hooting and hollering. Doctors, patients give us our identity. If a patient says put on a mask, I'm gonna put on a damn mask. Like, you're my patient and makes you comfortable. That's all I have to say. I would say, go in, hey doc, hey, do you mind for my comfort is wearing a mask? Sure. You can give them the mask if you'd like, right? Like, they should be able to do that. It's a sign of respect.
Yeah.
And it's something they need to be massively mindful. If they refuse, just be like, look, I'm your patient. This causes me a feeling of safety. And I'm saying this not to like, don't start up, like, try to like, meet them. Oh, come on, doc. Look, I'm your patient. I'm here. What an honor to have you as my doctor. Could you just do me this just because I live in a world of a little bit of a fear, especially now with COVID raging. I've had it before. I have complications. It would really help me. I'd better enjoy this clinical time with you.
Yeah.
Play to a doctor's ego. But it's sad that it's gotten to that part. But look, I wear masks because it's like reflex. I wore masks before they were cool in my lung clinic. But what I would advocate for patients is advocate for yourself. Please wear a mask. I like it. It's bewildering to me for doctors to say no. So
yeah, it really is.
Yeah.
And if you need help finding a mask, let me know. We'll find a local mask block for you. We'll get you connected, okay? But
Perfect.
Thank you so much for your time today. Go run up and do the thing you're gonna do. Have some coffee, send my olives.
You got it. I will.
Okay.
Thank you, Amanda. Bye, everyone.
Bye.
Thank you.